This lecture is about provisional restorations. Provisional restoration is defined as a restoration used in the period between tooth preparation and the fitting of a definitive one. Provisional restoration has three main functions: to maintain, assess, and allow resolution. By using a provisional restoration, we maintain the pulp vitality, occlusal stability, tooth structure, and acceptable aesthetics. And we can also use provisional restorations to assess new occlusal contacts and new aesthetics in case we are doing massive reorganized work. It also helps in allowing resolution of any active disease such as gingival inflammation or periapical lesions. By using a provisional restoration, we maintain several things. First of all, we maintain pulp vitality by preventing leakage through the exposed dentinal tubules, which could lead to irreversible pulpitis. We also maintain occlusal stability by maintaining contact with adjacent and opposing teeth to prevent horizontal and vertical tooth movement. Otherwise, at the fitting appointment of the definitive crown, the occlusion might be too high, or the proximal contacts might be open or too tight depending on which direction the crown has drifted. We also maintain tooth structure by preventing chipping of enamel from the prepared teeth, which would result in defective margins. And the last thing we maintain is aesthetics, especially in the anterior teeth. Although it's difficult to achieve excellent aesthetics using provisional restorations, since they lack translucency and they stain with time. Provisional restorations are also used in the assessment of new occlusion, especially in anterior teeth where anterior guidance is involved, since changing it without trial period could result in restoration chipping or TMD symptoms. It also helps us in assessment of new aesthetics with multiple crowns where the shape and shade of teeth is to be changed. A trial stage helps decide the definitive restoration's morphology, which is a good idea, especially if you have a picky patient. This photograph shows a provisional restorations from canine to canine, which was used to decide the length and the shape of the teeth before going to the definitive restoration. The use of provisional restorations allow the resolution of active disease, such as gingival inflammation. Provisional restorations should be made with proper contour, smooth surface, and good marginal seal to prevent plaque retention. Otherwise, it would result in inflamed gingivae, which would make impression making and cementation very challenging. It also allows the resolution of periapical lesions. Following root canal treatment, the tooth would receive a provisional restoration to provide cuspal coverage till the sign and symptoms of periapical pathology are gone. No definitive restoration should be placed while there is active disease. There are three mechanical requirements for any provisional restoration, which are durability, retention, and ease of removal for reuse. The first mechanical requirement is durability. The strength of provisional restorations is 1/20 of the definitive one, which makes it prone to fracture, especially at the connector site. To overcome this, you always use larger connectors and smaller impingers while taking into consideration the biologic and aesthetic requirements. In case of long-span bridges, which are more prone to fracture, consider using stronger lab-made temporaries instead of chairside. Provisional restorations need to be retentive, which is achieved by having adequate tooth preparation, closely adapted internal surface, and lining of preformed crowns, which we'll talk about later, and having occlusal equilibration, concentric and eccentric movements. The third mechanical requirement is ease of removal for reuse. The provisional restoration should be well made to withstand frequent removal and recementation between visits. Otherwise, you have to repeat the provisional restoration at each visit, which is time-consuming and costly. The properties of an ideal provisional material are ease of use, meaning having adequate working time, sitting time, and moldability. Biocompatible, which means non-toxic, non-allergic, and non-exothermic. Dimensionally stable, easy to polish and adjust, have adequate strength and abrasion resistance, have good aesthetics, which means color stability and translucency, easy to repair in case of fracture or chipping, and compatible with the provisional luting cements. The currently available provisional restoration material has three main issues: the polymerization shrinkage, which could lead to marginal gap, the exothermic sitting reaction, which leads to damage to the pulp, and the discoloration and staining, which leads to an aesthetic issue. As you can see from the photograph, the provisional restorations can be easily stained and discolored, especially if the patient is a heavy smoker. Provisional restoration failure could happen due to occlusal factors, which is the most common cause, inappropriate tooth preparation, which leads to thin restorations or inadequate retention, unacceptable aesthetics due to choosing the wrong shade or having inadequate polish, and having incorrect choice of material. Since choosing the material depends on the load being applied, the period for which the provisional to be worn, and the length of the span. The longer the span, the better it is to use a lab-made one. The main materials used for making a provisional restoration are polymethyl methacrylate, polyethyl methacrylate, epimines, bisacryl, and light-cured composite. The polymethyl methacrylate is supplied as powder and liquid in the ratio of 1 to 1.6. It comes in different shades. It is the same material used in cold cure acrylic in removable prosthodontics. It has the advantage of having high strength, excellent aesthetics, good polishability, and easily repaired. The repair could be done intraorally by having small amount added to the margins after coating the tooth with separating medium. The disadvantages of polymethyl methacrylate are: it's highly exothermic, and so if it's left on a vital tooth, it could lead to damage to the pulp, since the pulp is vulnerable to more than 5 Celsius increase in temperature. The free monomer is toxic to the pulp. It has a high polymerization shrinkage, which could reach 8%. The monomer has a strong smell and could irritate the gingiva, and it has a low abrasion resistance and low color stability. The polymethyl methacrylate could be used to fabricate provisional restorations, either chairside, and it comes as self-cured, or laboratory made, which is available as heat-cured or self-cured. And strength and color stability, the heat-cured is better than the self one. The second material is polyethyl methacrylate. It has a higher molecular weight than the PMMA. It's also used as a powder and liquid, and has the advantages of having less exothermic reaction than the PMMA. The monomer ethyl methacrylate is less toxic to the pulp. It's easily repaired and has good polishability. While the disadvantages are: it has lower physical strength than the PMMA, and so it's used for single crown or short span bridges. The aesthetics are inferior to the PMMA. It still has polymerization shrinkage and has unpleasant smell. The epimines are supplied in two-paste system. They have the advantages of having low exothermic reaction, very low polymerization shrinkage, and good flow properties. While the disadvantages are having low strength, they might cause sensitivity to the dentist, having tissue irritation, and difficult to repair. They are not very commonly used nowadays. The bisacryl composite resin which is the most commonly used chairside material for fabrication of provisional restorations. They are similar to the resin used in composite and come in an auto-mixing system of two pastes. They could be self-cure or dual cure. The Bisec rail have the advantages of having low exothermic reaction, low pulpal irritation, low polymerization shrinkage, good marginal fit, and no odor. While the disadvantages are, it's difficult to repair, have lower strength than the PMMA, and so it's used for single crown or short span bridges. It's softer, rougher, and more difficult to polish, has lower abrasion resistance, and is aesthetically inferior to the PMMA. It also has higher cost than the other materials. The light-cured composite resin is made from urethane dimethacrylate, known as UDMA. It contains no filler or microfilled and no monomer. The advantages are it has good strength and abrasion resistance, less pulpal irritation than the other types. The exothermic reaction depends on the intensity and duration of the light cure used. It has good color stability, long working time, easily repaired, and no odor. While the disadvantages are it has a rough surface and difficult to polish, poor marginal fit, brittle, and expensive. And now we'll talk about the fabrication techniques. In all procedures, an empty space or mold cavity need to be formed for the plastic material to be poured into it. The mold consists of two surfaces: the external surface form, which forms the external surface of the crown or bridge, and the tissue surface form, which forms the internal prepared tooth surface and or the edentulous span. The external surface form could be obtained by having it custom-made or preformed. The custom-made external surface form is a negative reproduction of the patient's teeth before preparation or from a waxed-up diagnostic cast. It can be made using impression, such as alginate or silicone in a tray, or vacuum-formed transparent splint made from the cast. The preformed external surface form are ready-made crowns with various sizes. They could be made from polycarbonates, aluminum, or cellulose. They are used for a maximum of 2 or 3 single preparations and cannot be used for bridges. The modification is done first by having internal relief, axial recontouring, and occlusal adjustments, and then it's relined with resin or polymethyl methacrylate material afterwards. As you can see, the preformed crowns could be made from tin silver crown, cellulose acetate, or polycarbonate crowns. If the preformed crown is tin silver or polycarbonate, it becomes part of the provisional restoration, while if it was made from cellulose acetate, the cellulose shell is removed at the end and it's only used as a mold. While using the preformed crowns, during the relining stage, the provisional needs to be removed and reinserted few times to prevent locking of the restoration in undercuts and to dissipate the heat. Any excess is removed using carbide burrs and polishing discs, but not diamond burrs and stone burrs, since they produce heat which melts the material instead of removing it. The polycarbonate crowns, they give the most natural appearance of all preformed material. They are available in one shade and can be modified to a limited extent by the underlying lining resin color. Comes in different sizes for anterior and posterior teeth. The cellulose acetate crowns are thin, transparent tooth form molds. They are available in different sizes and form, and the shade depends on the relining resin used. The shell doesn't bond with the resin, hence it's removed once the crown is made. The size is chosen by the mesiodistal width and not the length, since the length can be adjusted afterwards. The aluminum and tin silver crowns They are used for posterior teeth. The 10 silver crowns are highly ductile, which allows the crown to be stretched to fit the tooth if needed. Some of them are merely cylindrical in shape with no anatomy, which requires much more modifications. And now for the tissue surface form, there are three techniques that can be used to create the internal surface of the provisional restoration, which are the direct technique, the indirect technique, and the indirect direct technique. The direct technique is where the provisional is made directly on the prepared tooth or teeth. The matrix is filled with the material and placed on the prepared teeth intraorally. The patient's prepared teeth and gingival tissue directly provide the tissue surface form. The disadvantage for this technique is the potential tissue trauma and poorer marginal fit because of the provisional having to be removed before its final set to avoid engaging the undercuts. The steps for the direct technique in case of using preformed crowns start by choosing the right size and form, which is then trimmed to match the curvature of the finish line. After that, lubricant is applied to the tooth and gingival tissues to prevent contact with the monomer. The material is then mixed and loaded into the preformed crown and placed directly on the prepared tooth. Make sure to remove the excess before the material is completely set. After 2 minutes before final sitting, loosen the crown by slight rocking motion and remove it. Place it in warm water until fully set, which takes around 5 minutes, and then trim the excess using carbide burrs and check the occlusion in eccentric and centric. After that, polish and cement. In the indirect technique, an impression of the prepared teeth is obtained and the provisional is fabricated on the resulting cast, which is usually done in the lab. It's used when the provisional is needed for a long period of time. The provisionals fabricated by this technique are usually highly aesthetic, have high physical properties, good marginal fit since they are fully polymerized before removal, and the teeth are spared the negative effect of the exothermic reaction and the free monomer, but the problem is its higher cost since it's made by the lab. The steps for the indirect technique starts by obtaining an external surface form from a diagnostic wax-up. After tooth preparation, alginate impression is taken. The resulting cast is then trimmed to allow proper fitting of the matrix, and separating medium is painted on the cast. After that, the matrix is loaded with the material of choice till the level of the gingiva. The matrix is then seated over the prepared teeth, and the cast along with the matrix in place are then placed in warm water around 40 Celsius in a pressure vessel for 5 to 10 minutes. After the material is completely set, the matrix is then removed from the cast and the provisional restoration is then trimmed to remove the excess and finally polished with discs and pumice. All provisional restorations should be evaluated inside the patient's mouth before cementation. They should have proper contact points, contour, free from surface defects, have adequate marginal fit, and correct occlusion. Defects are repaired with adding material, and occlusion is checked with articulating paper, followed by removing any high spots in centric and eccentric movements. Otherwise, the restoration might be lost or fractured. The last one is the indirect direct technique, where the provisional is fabricated using indirect technique, then relined directly inside the patient's mouth. A custom-made preformed external form is produced indirectly on an under-prepared diagnostic cast. The result is called a shell temporary, which is then relined intraorally, similar to the way a preformed crown is made. It saves chairside time when multiple preparations are made. The steps for the indirect direct technique starts by taking an impression of the unprepared teeth, pouring it, and obtaining a cast. After that, the external foam is prepared with impression material or vacuum sheet on the same cast. Minimal preparation of the abutment teeth is done on the cast to provide space for creating the shell temporaries. The stone is coated with separating medium, and the resin is syringed into the external foam to create the shell temporary, which are completed in the same way as with the indirect technique. Finishing and polishing of the provisional restoration is done at the end. After fabricating the shell temporaries in the lab, the teeth are prepared inside the patient's mouth. The preformed provisional is then tried in to make sure it seats properly, and if there is anything that prevents seating, the internal surface should be relieved. Separating medium is applied on the prepared teeth, and reline of the provisional is done for better adaptation. Before the complete set of the relining material, remove it and place it in warm water to complete the set outside the patient's mouth. After 5 minutes, the excess is removed and finished with finishing burrs and discs. After checking and modifying the occlusion of the provisional restoration, doing the needed polishing and finishing, it's ready for cementation. Temporary cements are used with low strength for ease of removal. They are used to seal the provisional restoration, which prevents leakage and pulpal irritation. The ideal properties of temporary cements are the ability to seal against leakage, strength consistent with intentional removal, low solubility, compatible with the provisional material used, ease of use, good working time, and compatible with the final cement used. Permanent cements should not be used with provisional restorations since they have high strength and difficult to remove. Zinc oxide eugenol is the most commonly used provisional cement, although eugenol has a softening effect on methacrylate resins, especially if it comes in contact with it before the complete set of the provisional restoration. It also affects the polymerization of resin cements, and so if we intend to use resin cements as a definitive cement, we should use zinc oxide eugenol free instead. If we require more strength of our cement, for example, if we lack retention in our preparation, we would use reinforced zinc oxide eugenol. And if we require less strength, for example, we are temporarily cementing a definitive restoration, we would mix it with modifier, and if we don't have the modifier, we can use Vaseline instead. The most commonly used brand for temporary cementation is Temp Bond. It's available with or without eugenol. In this photograph, you can see the Temp Bond NE, where NE stands for non-eugenol. It's available as a two-paste system. One is accelerator and the other is a base. We would mix 1 drop of each using cement spatula on a glass slab or a pad. If we want to weaken the cement, we would use a third tube known as modifier. For example, if we are temporary cementing a definitive crown, for example, we're doing a root canal treatment underneath and we want to remove it between visits, we would use the modifier to make it easier to remove it. Otherwise, even if we use the temporary cement, removing a definitive crown would be really difficult. The steps for cementing a provisional restoration start by lubricating the external surface of the restoration with Vaseline to facilitate removal of any excess cement. Equal amounts of the base and catalyst are mixed, with the modifier added if needed. Only a small amount is applied on the internal margin to provide good marginal seal and avoid incomplete seating. The provisional restoration is then seated intraorally on the prepared teeth and held still until it completely sets. Any excess is removed using a probe or excavator and a floss. As we said earlier, one of the requirements for a good provisional restoration is ease of removal, since it needs to be removed at the beginning of each visit, for example for taking an impression or for metal try-in, and put back at the end. For that, bridges are removed using an instrument called bridge remover, and single units are removed using a hemostatic forceps. To do that, place a gauze intraorally to avoid inhalation, and grasp the provisional firmly with the hemostat and gently remove it using a rocking and unseating movement. Any excess cement left inside the provisional restoration is removed using a spoon excavator or an ultrasonic scaler for it to be reused at the end of the visit. And that's the end of our lecture. Thank you for listening.